By the way, can you hear me? I don't know if I'm supposed to use some mic. I don't need a mic. Can you hear me? Yes. All right, hell with it. I don't believe in mics. In fact, I'm going to use West Virginia PowerPoint. I'll just move my hands up and down. Today, sometimes we overdo the technology. And so today I will just speak off the cuff. Well, we're told we have the best healthcare system in the world, and there's some evidence to support that. Certainly, people live long and productive lives in our nation, longer than before. The quantity of life and the quality of life has improved over time, and the healthcare profession have been critical in that happening. But at what cost? At what cost? And did we do it in a way that would optimize society's resources and human happiness? And I think the answer to the latter question may well be no. That we've done many things in our society, particularly in the area of healthcare, that have not had positive effects. In 1950, the typical American family, according to Bureau of Labor Statistics, spent 26% of their money on food. Now they spend 13% of their money on food. Over time, the amount of resources used to buy the basic necessity of life has declined because we've become wealthier as a nation, and although we eat more, probably eat too much, and we eat fancier foods than we did back then, and we go to the restaurants rather than cook them ourselves, in spite of the increase sort of qualitatively and quantitatively in the amount of food we eat, it has become less of a burden on us. Automobiles, the same thing. Believe it or not, we spend a smaller percentage of our budgets on automobiles than we did 60 years ago. Even though we have more automobiles, they're better automobiles, they have all sorts of gadgets on them. I can't figure out half the gadgets for my own car. And so life has, for most of the things that we do and buy, it's become less of a burden. With healthcare, though, it's a different story. And indeed, there's two areas where the costs have risen a lot over the last several decades. Not only have risen so much that it absorbs more of our income rather than less. One is healthcare. The other, by the way, are college tuition costs. Surprise, surprise. The government has a big role to play in both. We'll come back to that in a minute. Just out-of-pocket costs for the average family, according to the Bureau of Labor Statistics, in 1950 was 6.6% of income for healthcare costs. In 2010, it was 6.6%. Same percentage point, same burden, even though in 2010, the federal government and the governments were picking up an enormous proportion of the costs and subsidizing enormously. In spite of all of these subsidies, the burden on the public health care had not declined, and indeed was stable. So what's going on? Why is this happening? And of course, a partial explanation, and an important part of the explanation, is that in 1960, life expectancy in the United States was actually 1950, life expectancy in the United States was 68 years, 68.2 to be precise. Fast forward 60 years, it's 78.7 years. This is 2010 data. That's a 10.5-year increase in life expectancy, and 10.5 years, those years in the 70s, and for some beyond in the 80s and 90s, are expensive years from a healthcare perspective. The cost of keeping people alive rises with age. So, and of course, we've had improvements in the quality of healthcare over time that manifests itself in these longer life expectancy. So some of the greater resources to deal for healthcare is to be expected, and indeed we rejoice over it because it has kept us alive. But the total burden on society of health care has expanded precisely at the same time that the government's involvement has expanded. I don't want to bore you with a lot of facts, and that's why I didn't make up a PowerPoint. Also because Nick wasn't paying me very much, frankly. 2 pieces of pizza eaten quickly, but they were Donato pizza. It wasn't. In 1960, here's my West Virginia PowerPoint. In 1960, 5 cents out of every dollar in America, American output went for health care expenses. 5, 5 1/4, rounding off a nickel out of every dollar. By 1980, it was up to 9 cents out of every dollar. By 2000, it was up to 13 cents out of every dollar. Now it's about 16 cents out of every dollar. The numbers vary a little, depend what you count. You count capital expenditures, say, for new facilities and all. There's some issues in accounting that have to be dealt with. But these are numbers right out of the last statistical abstract of the United States. So the costs have tripled as a proportion of our income. And of course, our income and output is grown enormously over time. The total expenditures in healthcare in the year 1960 were $27 billion. They're almost exactly 100 times that now. Now there's a lot of inflation in there, and so allowing for that, the increases aren't as great, but they're enormous. What's going on? Well, the biggest single change from a financial point of view in the healthcare system is there's been an enormous increase in governmental involvement. Let's briefly trace the history of federal involvement in medical care. And it's kind of an accidental beginning. Accidental. It's the law of unintended consequences. During World War II, the government, in order to keep inflation down, put limits, controls on wages. Companies couldn't raise wages or they would violate the law. There were wage and price controls, which, by the way, economists will tell you are generally inefficient and just suppressed, do not really stop inflation, do not stop the problem, create shortages, have all sort of unintended side effects. But we put in wage and price controls in World War II, and companies were desperate for workers, and one thing they said is, hey, we'll offer workers, instead of wage increases, we'll offer them health care benefits. And so, how did private health insurance in the United States really get started? With the World War II era. Before World War II, there's hardly any health insurance in the United States. As most developing countries have no health insurance. I was in Malaysia in 1978. I had to go in the hospital. I had a spinal tap. It was a pretty significant visit. I paid $25 a day cash. No big deal. Even for my services, actually I got reimbursed for it. But by the Malaysian government. By the way, the hospitals had dogs running around in the room. Cheap health care, but nonetheless effective. I'm still alive. We begin this series of the first of 3 big problems with the American healthcare system from an economic point of view. The first problem is the overwhelming dominance of third-party payments. Someone else is paying the bills. The consumer is not paying the bill. The producer isn't paying the bill. Some third party. The first set of third parties were private insurance companies, but even that was incentivized by the federal government providing incentives for companies to give health care benefits instead of wage increases. So that was in the 40s. There were provisions in the 1948 tax reform that allowed deductibility of health care benefits, which previously were not deductible. And that provided the government implicitly was subsidizing the purchase of health insurance as opposed to the purchase of other things. So the government was saying, we want you to buy health insurance. We'll help you pay for health insurance. We'll allow you to take an income tax deduction. So private health insurance grew during the 40s and 50s. But in 1960, if you had a health care need, there was a large probability that you would pay the bill yourself with cash. And the secondary possibility would be, if it were a big expenditure, you would supplement that with insurance payments from a private insurer. But there would be no federal provision. Well, of course, in the mid-60s, we adopted Medicare and Medicaid, and the situation changed dramatically. The government started involvement with a system they said would never be a very large. Medicaid would be a relatively minor item, and we know now that Medicaid now shows enormous percentage of the budgets of states. I've been consulting with our current governor of Ohio, Governor Kasich, on the budget, and they're just being, eaten alive by Medicaid. And of course, with Obamacare, it's worse than I'll say a few choice words about Obamacare in a minute. I have high blood pressure, so I have to sort of ration my use of that for medical reasons. I hope you appreciate this. All right, let me say that there have been three big problems that have pushed up healthcare costs where governmental involvement has been very important. One, and I'll just mention them, 1, 2, 3, and then I'll talk about each one of them for a bit. One, the government's pushing and promoting of third-party payments, already mentioned, is usually important. If someone else is paying the bills, your attention to costs are reduced. As a patient, your concern with costs, even as a provider, are reduced. You don't have to worry about, now that's of course subject to enormous qualifications these days, but at least in principle that's true. A second problem has been the enormous growth of defensive medicine, which was a non-existent term 40 years ago, didn't, to my knowledge, exist, as the growth in the use of malpractice cases and so forth has expanded. And this is obviously a public policy issue. And I, for a year, I could have made far more money working for Whiplash Willie, the local attorney, suing doctors, than I could teaching economics. I'm good, Frank, I guess this is bragging, but I'm good in a courtroom because I'm a teacher. Teacher, that's what you do. You persuade people. So I can persuade juries. I persuaded juries to do some of the damnedest things. So the tort system has worked. So we have a lot of testing going on. It may have some marginal benefit, but often it's done partly to cover the butts of the providers. And all is being dictated by public policy. I could tell you, actually very, very tempted to talk about a couple of those cases. Just they're kind of interesting. But I better not, because it could get a little close to home. One of them, someone who had a connection with this college, and I'd probably be in deep doo-doo if I talked. A third problem is one that is not usually even talked about, and it's not even specific to medicine so much, is I think the government's net effect on medicine has been to decrease the supply of medical care and decrease the supply of physicians, for example. So the government has, through third-party payments, we could put it this way, they've increased demand, they've reduced supply, and they've raised costs through defensive medicine. So there are other things, but that's enough for what you're paying. And what I know. My knowledge, you're pushing the limits of my knowledge on this, by the way. I'm not quite sure how Nick got a hold of me, but he must really desperate. So let me do something. Now, the next few minutes is going to be the intellectual equivalent of having a hemorrhoid operation without anesthetics from an unlicensed French physician who has just returned from a lunch full of, where he drank a lot of good red French wine. In other words, it's going to be painful. I'm going to talk about 3 pictures, and I handed out in the most crude form in this day of modern technology. I grabbed a piece of paper and a pencil, and I drew 3 graphs quickly, and I Xeroxed a few copies off. And so that's what you're getting. If this were for some spiffy group, I probably would have had the computer drawn, or I'd done it like on a computer. Do you have these little pictures? Yeah. Nick, you passed about it.
Does anybody need one?
I'm going to use the most elementary techniques in economics, demand and supply, and I'm going to do it as simply as I can. Medicine is like anything else. The demand for medical services, healthcare services, is responsive to the price. If the price is too high, people won't buy it. Now that's less true of healthcare services than most things. Most times most people who go to the doctor going for a reason, they're sick, and they are really pretty desperate to get help, and so they'll pay. But there's some sensitivity to the price. If the cost to go to the doctor is $1,000 a visit, maybe, you'll read your Bible and all, prepare for death. If the price is $20, you don't hesitate to go. If it's $0, you're there on the drop of a hat. I have nothing to do today. I think I'll go to the emergency room. So the demand curves, as we call them, at lower prices for medical services, people want to buy more of it, so the quantity grows as the price declines. So you've got that downward sloping line, but it doesn't have a sharp, it's not very horizontal, it's more vertically slope, but it's nonetheless downward slope. So the first graph shows that as the price of something falls, people buy more. Similarly, what about the supply of medical services? Well, if the amount of money paid to providers is high enough, you'll get more provision. Doctors, however, are limited in number, hospitals are limited in space, and in the short run, you can't dramatically alter supply. But if the compensation's big enough, some doctors might work 60 hours a week rather than 50, and not that money is the only determinant of why you perform medical services, but it is a consideration. And so the supply curve slopes upwards, higher prices of medical services, the more remuneration there is for suppliers, so there's more supply. So you have a downward sloping demand curve, an upward sloping supply curve, and they cross at some price. The first graph shows that over time, the expansion in providing aid and assistance to individuals through Medicare, Medicaid, and some other programs, but particularly Medicare and Medicaid, has worked to increase the supply. At any given price, more people want to buy medical services than they would otherwise, because someone else is paying for it. You don't pay. This is the price to society. It's not the price to the individual. So the individual, so the demand expands, and if the supply is relatively fixed, what happens over time, as first class shows, prices go up. And they don't go up a little bit, they go up a lot because of this inelastic demand for medical care services, because of the fact that people are desperate for medical care services, except for certain discretionary types of medical care. By the way, this is a slight aside. As a matter of public policy, the governor was going to propose expanding the sales tax to include other services beyond what had previously been taxed, and this is hotly contested. And I was called in as a consultant. I said, what are you doing about medical care services? They said, what should we do? I said, well, depends what your objectives are. I said, you might want to, you could consider taxing plastic surgery, cosmetic surgery, things like that. It's not a life or death health care provision. It's something that's discretionary. It's probably akin to having a massage treatment. If you're going to tax Ohio State football game tickets, which of course in Ohio is the ultimate example of burdening the population, you might want to consider this. They said, no, we're not going to do it. Healthcare is off the table. They were for a while, by the way, going to tax caskets and burying people. So once you died, your prayer game, but up to then, the act of staying alive is sacrosanct. So that's interesting. What will happen, I don't know. So anyway, the price of healthcare has been pushed way up because of the increasing demand. The mandate under Obamacare aggravates that even more. More increase in prices. So I'll come back to it. Of course, they have an answer to that. We'll come back to it in a minute. It gets worse. Now, I also alleged in my early comments that healthcare, the government's provision, leads to a reduction in supply. I think the tort explosion and the explosion of malpractice is a supply reducer. And indeed, there was a prominent graduate of this college, who I know, some of you may know, who gave up the practice of medicine because he was sick of getting sued. He just was sick of, the risks were too great. He went to become, the one I'm thinking of, he went to become a pilot. A non-risky occupation, flying airplanes. So the defensive medicine and the whole area of tort probably has reduced supply. But here's some other things that have reduced supply. What about a nation which tells its most productive citizens, we think you should be paying a lot of money to help other people? Now, many people on egalitarian equity grounds say that that's good. But is there a point at which that kind of philosophy has unintended consequences? Under the current tax law, the top marginal tax rate exceeds 43%. A lot of doctors are in that tax bracket. They live in the state of Ohio. They add in their state and local taxes, school district taxes and all. They're paying about half of their income at the margin in taxes. So as those tax burdens rise, there's some people say, to hell with it. It's not worth working that hard because I don't get to keep that much. And that is a sort of a disincentive for some maybe to go to law, to medical school and receive medical services. Another thing, the cost of going to college has gone up a lot. And the cost of going to medical school has gone up a lot nationwide. I'm not speaking specifically to, I think we're kind of the good guys, aren't we, in that area? No, we aren't. No. You're up to your asses in debt, basically. And that, too, is a function of public policy. I don't have time to go into that. I've written a book about it. I run a research center on it. But we are having 13% default rates on student loans. A lot of this is medical loans. A lot of this is medical loans. I have a doctor friend who owes over $100,000 in debt who came to me and says, I don't know what to do. He's like wants to blow his brains out because he's working in an OR, or not OR, an emergency room, making close to $100,000 a year, but he's got several children, and kids going to college, and the burden of that debt is just looming large. And people hear stories like that, and they say, I'm staying away from medicine. So we go to picture 2, the second graph. Let's suppose at the same time as we have that big increase in demand that we just talked about, we also have simultaneously occurring a reduction in supply, which is denoted on the graph by that supply curve moving over to the left. At any given price, less is supplied than before because of all of these hassles that doctors have to go through, high taxes, malpractice, and so forth, many of which are government generated, or at least public policy related. Public policy could stop this. We could go back to caveat emptor. Let the buyer beware when you go to the doctor. We could go back to people signing waivers saying, I understand this doctor's a pretty good doctor. Sometimes mistakes happen. Sometimes accidents happen. Sometimes random events happen. I may die. Tough. I accept this. And sign a liability waiver. We can't do that anymore, effectively. So let's say we have the demand curve shift to the right, which I think it has a lot, and we have the demand curve shift to the left. We get a new situation where the quantity demanded and the quantity supplied are equal, which is the market price, the market stable situation, what we call equilibrium, at a point which involves enormously higher prices than before, but not necessarily any increase in quantity. I am not sure that we provide more medical services or less medical services than we would if the government were not involved at all. If the government were not involved at all, my guess is we would still be providing as much medical service as we are, except we'd be doing it at a lot lower cost. And I'm not saying lower income for physicians, because you wouldn't have a heck of a lot of expenses that you have there. So there's that. Let me go on to the third graph. Make a few more comments. I want to say a few things about like Medicare Advantage, a few things, let you know that I know a little bit about the current situation. No one I know has read the whole 2,800 pages of the Obamacare bill. I didn't have any of you. There's a two. Oh my God. Can I have your autograph? It's a relatively arcane and long document. The third graph. So, healthcare prices are soaring. What are we going to do about it as a government if we're government-oriented? Well, we're just going to say you can't raise your prices. We're going to put limits on what you can charge for doctor services, physician services, for tests, and so forth. We will create a bureaucracy that will try to limit this. So we'll put price controls on, meaning we'll say the price cannot, for any given service, think of this as a specific service, cannot exceed some X. But at X, the quantity demanded exceeds the quantity supplied. What does that mean? Shortages, meaning that you can't walk into a doctor's office or a hospital and immediately get care necessarily. Some rationing occurs. Rationing can occur on the basis of some medical criteria, can be on the basis, you know, they can ask for your voter registration card. If you vote Democrats, you get care. If you vote Republican, you don't get care. If you vote Libertarian, you're killed. It could be based on age. And we use we actually do ration some services on the basis of age now. Heart transplants and so forth. Probably kidney, liver, various high-cost medical procedures are rationed. And so we have the potential of shortages. You talk to people from England or Canada or France who want to have a heart transplant. Can you get one in a week or a day or 3 days? Maybe. But except in many cases, it's a long wait. Several months, year and a half. I have friends in Canada who are waiting 2 years for procedures that in this country, if you wanted to, you could get within 30 days. Within 3 days, if you wanted it better. So therein lies a series of problems. Our healthcare system is costly. We're now spending 16% of our GDP. We're not really probably getting fundamentally more healthcare than we would have had this intervention not occurred at all. Now, can I prove that? We're talking about a counterfactual, something that is different than actually existed and is very hard to prove, counterfactual proposition. But I think economic theory supports it. By the way, if you go around the world, what percentage of GDP goes for health care, even in the European countries? And by the way, the European countries are no models, but 9, 10, 11%. France, Germany, Britain, we're around 16. Now we offer, of course, some, the state of Ohio, which is, at the pits of the world on almost any criteria, is pretty good in healthcare, and we have some. We are actually we export medical services to overseas, meaning that the King of Saudi Arabia comes to the Cleveland Clinic and rents downtown Cleveland for a month or whatever, which today is pretty cheap to do. So we have that. Now, on top of this, of course, we now put in Obama. Nick is starting to look worried. I'm going to quit in a couple minutes.
No, keep going. We're good.
Am I okay? You're awake, which is whenever you give lecture. Hey, yes. You want me to keep going?
Rock on.
Rock. Okay. Whenever I give noontime talks to Rotary clubs. When I speak to Rotary clubs, most of the members of the audience are about 85 years old, and they're ready for their afternoon nap. And so I have to look around and see if anyone's awake. You're doing pretty good in that regard, I must say. I'm a member of the local Athens Rotary Club, and I'm well below the average age. And I retired from OU allegedly 11 years ago. That's another scam. I actually testified before the Ohio legislature yesterday where one of my sentences, someone was taking this down. I said, quote, I have been ripping off taxpayers for 47 years. No representative from a university ever said that before the Ohio legislature. The Ohio University lobbyist was in the audience turning green. I love it. Anyway. So Obamacare comes along. There's so many things in Obamacare that relate to all this. You hardly know when it starts. I just picked up today's Wall Street Journal. And I'm already getting a laugh. You probably read the editorial in the Wall Street Journal. It's about something called Medicare Advantage. Medicare Advantage provides an opportunity for seniors in some situations to not derive their health care benefits directly from Medicare, but through private insurance provision. I use Medicare. I had surgery the day before yesterday, and I had my Medicare Advantage card out, and I gave it to them, and they gave me the best of care. This is up at Ohio State. It's cool. It's a relatively less inefficient, more efficient method than having the government bureaucracy dictate every step. 29% of seniors, according to the journal, I assume that's right, the journal is never wrong on anything, 29% of seniors have Medicare Advantage. The Obama administration, according to the story, is working tooth and nail to kill off Medicare Advantage. Now, whether that's fully true or not is maybe subject to some debate, but that's what the journal says, and I'm inclined to think it's probably true. We have the whole issue of should states be bribed into participating in expansion of Medicaid programs. And the governor of Ohio has decided that we should take some federal money because there, and it would allow some Ohioans to receive medical services that currently don't, but it is an expansion of a broken system, and at a considerable cost, and of course ultimately that federal money would be pulled away. The federal government has no money to be giving out anyway. There are $1 trillion deficits and everything. So we have a serious problem. The long-term problem, of course, is the ratio of elderly Americans to the total population is growing, in part because of the very successes of our healthcare system. And that it is getting so that any nation with any provision of any kind for healthcare is going to face increasing burdens of healthcare costs if we are going to continue to want to save and maintain human life. So that problem is growing. The nation's financial situation is worsening. We have $16 trillion in federal debt, but that just is the strap that scratches the surface. We have unfunded liabilities for Social Security and for the healthcare system, particularly the healthcare system, several times larger than the federal debt. Minimally $50–60 trillion. 16 trillion is the formal debt. We have another X number of trillion, and X is pretty big for Social Security. But the big enchilada of the whole thing is the medical system, the care liabilities that we have incurred under Medicare and now under Obamacare. You're totaling, add it all up, I've seen some estimates in excess of $100 trillion, and that's huge bucks, folks. You divide 100 trillion by 300 million or 310 million, what do you have? Trouble. Some of you are smart, you'll not be able to do that. Do they teach math anymore? 300 billion would be $1,000 apiece, 300 trillion would be $1 million. It'd be $300,000 a person in obligations, $1 million for a family of 4. That's how much obligation we have taken on as a nation. This is far greater than most families have taken on in mortgages and other debt. So our public authorities have made enormous commitments at enormous costs that this younger generation is going to be paying. And a lot of them are healthcare. A lot of them are healthcare. Over half of them is healthcare. So we're being doubly screwed, if I may use a technical economics term. We're being screwed the first time because we are paying enormously for our healthcare services, and we're not really getting all that much more than we would have in a world without governmental involvement. And secondly, our children and grandchildren, because we're not paying for these bills now, we're borrowing it from the Chinese. So we are going to be indebted to the Chinese. Some of us, our children and grandchildren, are going to work as gardeners for Chinese industrialists. Probably not, but makes a good line. Because we are deeply in debt to it. We're losing our superiority, economic superiority as a nation. It is weakening our moral fiber. People are losing a sense of responsibility. It is promoting poor health care practices. Why practice good health care? You can go to the emergency room anytime anything happens. You can, the government's giving you a check and you can go out and buy anything you want with it. And Michael Bloomberg's trying to stop large pop consumption in New York alone isn't going to solve that problem. Some of you, one of you has gotten up and leave, and one of you fell asleep briefly. So there are indications of the first principle of economics is starting to set in, the law of diminishing returns. And so at this point I will stop and take questions. And your esteemed advisor in the back has the first one. Yes, sir.
Dr. Vedder, I don't know if you've looked at this, but Heritage had some nice graphs that delineated the proposed expansion of state Medicaid programs covered under federal reimbursement within the cost obligations associated with those states after federal reimbursements stop. And in the case of Ohio, after 2016, the federal money stops flowing in, and the state now assumes responsibility for covering the cost of the Medicaid expansion. Up to about 2026, I think that leaves us with a liability of about $1 billion in the hole. My question is what are your thoughts about the movement of physicians as those economics change? Because the response will be from the state of Ohio to cut Medicaid reimbursements at a time when patient panels are made up of 30% Medicaid patients. Economically, it seems to me that doctors will not be able to tolerate that and may seek employment in states that have not undergone the Medicaid expansion so they can maintain a living and pay that debt that they've incurred. Does that resonate?
I think that is a very real concern. One thing that was is migration. I spent a half lifetime doing migration studies. Wrote a dozen papers. In fact, I got a little mini book that is coming out shortly by the George W. Bush Institute on Immigration. So I completely concur with that. Professionals are very sensitive to economic indicators and will move, not at the drop of a hat. I mean, they got licensing requirements, same thing other people do, family obligations and so forth. But I think that states where there is a larger amount of federal involvement, state involvement, Medicaid involvement, will have less desirable physician environment, and that physicians will move. I will go a step further and say, I don't understand why medical school applications haven't taken a ton. Law school applications have, which, by the way, is a good thing for society. I have always favored when we get in hostile negotiation over tariffs that we offer as a sacrifice to send them, say, 100,000 lawyers in return for the 3 people we want back, or whatever it is. But I think this is a serious problem. I think we're going to have, now, you know, although I have to be honest with you, I looked at the statistics on doctors per 1,000, and there are a lot of Europeans. Sweden has far more than we do. Now, Sweden is no great shakes of a nation in terms of many things, but there are other factors involved besides this, but I do think that it will have a negative effect. Any other questions? Yes, sir. Yeah.
In my entire career, I have seen that government is the problem throughout. So my question to you is, I have seen no indication likewise that they are getting out of healthcare or moving away from it. So what are we to do other than to just take this? I mean, what
You thought about Turks and Caicos. I'm absolutely serious. I just came back from Australia. I've been looking at it. I love the Turks and Caicos. They're a British Crown colony. And if you sort of take the view that our breaking up from Britain was a little bit of a misunderstanding we had, and they wanted to tax us without representation. What else is new? I mean, what the hell? And the Queen, we all love the Queen. She's a hell of a lot nicer than Obama. It's a British Crown colony, 0 income tax, 0 this and that. I'm kind of half serious here. And I've talked to a lot of expats. They're getting out. They're leaving. Now, I'm a loyal American, and I think it would be awful if we had a lot of people leave our country. But I do think groups like the Benjamin Rush Society can mobilize young people into realizing that the current paradigm is not working and that we can affect change. I'm a little discouraged about this. I used to work for Congress. I am not a total naive on political issues. I have advised politicians all over the world, from Vladimir Putin to Benjamin Netanyahu, some very interesting characters, mostly outside the U.S. The American politicians generally avoid me. But my view is we have a serious problem in our nation with the political process. It's dysfunctional. It's not working right. And the intellectual community isn't helping because academics tend to be very leftist in orientation for a very simple reason that no one, it's very simple. They're all paid for by government. They're all financed by government. So they love anything government does. So we're not, we need sort of a classical liberal revival, I think, sort of a second enlightenment, as it were. And we need it at the intellectual level, we need it at the political level with politicians who have a certain amount of guts and a certain amount of integrity and are willing to take political risks that most people aren't. That's a poor answer. I'm discouraged like you are, in short. But I have to leave it at that. Are there any other questions? I know some of you have little things like classes to go to.
Just to go along with what Mark was saying, I mean, I feel like the only way to change it is for physicians to go into policy making, which we don't have time for that. So
yeah, I've talked to a lot of physicians about this, and that's their standard answer. Is, I could be a physician or I could be a politician. I can't be both. Now, having said that, I know a guy who got to be a friend of mine whose mother, by the way, graduated from OU, Ron Paul. Did you know Ron Paul's mother is a graduate of OU? Ron Paul's wife, Rand Paul's mother, is a graduate of OU. And there are politicians, there are physicians who manage to balance these two things. But it is difficult, and there are sacrifices. There are sacrifices both professionally, in terms of the medical career, and with respect to family. When you get into politics, it's brutal in terms of your family life. Trust me, I know. Yeah, so any other, I guess better move on. Yes, sir.
Are there situations or instances where government can play a positive and pivotal role in healthcare?
Probably. Can government ever play a positive role? The law of diminishing returns, that I mentioned earlier, has some applicability here. Probably at small levels of involvement. Some government involvement might have beneficiary effects. I do think one thing the government could do that they used to do, and to some extent they still do, is encourage private initiatives to promote good health, including charitable hospitals, aid to indigenous people who have medical problems, and things like that. That can be done through tax provision and all. It's modest government involvement, but it's a relatively non-intrusive, and I think probably a very favorable one. Would be an example. Well, I suspect Nick is standing up, which means it's time for me to leave. So I want to thank you for listening.